The next speaker is Professor Stephen Kinoti from Fio Corporation, who will be talking about data capture through workflow guidance for systems health, for stronger health systems.
Good morning, everyone. Amujambo. Some people know. Yeah. Let me take this opportunity, first of all, to thank Professor Mukaya Mamburi for inviting me. This is exciting for me because it's in the midst of discussing collaboration that this idea came up. And he talked about, there is an innovations day that is going to be coming up. And I know you guys are involved in innovations and technology for health. And would you be interested in participating? It was something so exciting for me, I couldn't say no. I had to say yes, and I did. And here I am. So thank you very much, Mukaya. Asante sana. Right. I would like to thank the Tufts community as well for making it possible for me to come here. I listened and was really moved by Gloria's talk this morning. I happen to be a pediatrician too. I happen also to have survived neonatal meningitis. My mother tells me, long before I became 1 month of age, I was hospitalized in a Catholic Sisters Hospital in Mojua. I don't know whether you've heard of that. And for a month. And she had this vision in her head, or had a voice that said, your son will survive. I happen to have survived because I'm right here. So the testament and the call that Gloria made a lot of sense to me. And I would like to really also emphasize that. I also was moved by the fact that just recently she climbed Kilimanjaro. I did that in 1964. And I was lucky to get up to the summit. And I completely agree with your demonstration of how you have to do it. And like many other things. I'm here to talk to you about technology and its application in improving health care, particularly decentralized medical care. We all are aware of how the systems are organized today. Let me see whether this works. It does. Most of you sitting in this room are probably working in a centralized healthcare system, and many others, and many of you may have worked in a decentralized healthcare system, in a clinic, in a health post, or the kind of services, facilities that Gloria and others have talked about in the periphery, including the presentation from India. The kind of technology that is made available in those facilities touches a very small portion of the international global community. But we know majority of the people that we serve are in decentralized facilities, the healthcare system. In communities, in health posts, dispensaries, health centers, and sub-district facilities, where hardly any of this technology gets to. What do we want to do really is provide care. That's what we want to do. The nurse, the clinical officer, the laboratory technician, the traditional healer, they want to provide care. But they are also required to gather information, to gather data. There is a tension between providing care and gathering data. They can't exactly happen at the same time based on the previous systems that we have run, the paper and pencil-based systems, or if you want computerized systems to push them way down to the community and the health post and the health center and so on, that's a very high cost upfront in every program. it becomes very, very difficult. So how do we transform this tension of care and data into something better? And that is actually care and data. Fionet, the technology I'm going to be talking about, was designed to address that question, that problem. Fio Corporation, headquartered in Toronto, created Fionet and called it the term Fios. That was coined out of a Malagasy word called Fio Banana. Like V instead of banana, V, banana, Fio Banana, meaning treating strangers like family. Greetings from Dr. Greenberg, who first time heard about that, and who is the founder and CEO of Fio Corporation, utilized that term for the company because he believed that's what his mission was in 2006, and established Fionet following the term, using the term Fio Banana. What are we talking about? We are talking about utilizing available technology that integrates cloud services, information services, to point-of-care diagnostics, to care and treatment, to data capture, data use, and feedback to improve services out there in the periphery, in the decentralized facilities. What system is available to do that? Today we have something we call RDTs, rapid diagnostic tests. We're all familiar with these. Actually, the chemistry in these cassettes is extremely good, very powerful. But we lose that power of accuracy, of sensitivity and specificities above 98% because of human error, because of processing. Because the processing requires someone to prick an individual, put blood in the right place in the test well, get a buffer, put it in the buffer well, allow a period of time to incubate, and because it uses colloidal gold lateral flow to migrate and hit an antigen and antibody and create a reddish line. Red at the right time provides fantastic accuracy. We have these for HIV. This is KHB for HIV. We have for malaria. We have for dengue. We have for various different conditions, and they're emerging. And very soon we're going to have one for Ebola. Fortunately, the Gates Foundation, WHO, and CDC have asked Fio Corporation to actually work with the people producing RDT so they can be customized to be read. These, when they're read by people in the communities using a human eye, are associated with about 25 to 35% error rates, and that's been shown by WHO. Now, just imagine, last year for malaria alone, they used 800 million RDTs. 30%, 25-30% of those done wrongly, and those people getting prescriptions of ACT, at the same time, because they're not quite sure what they're doing and everything else, also giving them antibiotics, it's a tremendous wastage and causes major problems in terms of drug resistance and other complications. However, if you use a system that automates processing of the RDTs, reading of the RDT, ensures the right incubation period and rings a bell to you and makes a noise and reminds that, oh, this is the time to read it, and then returns a positive or a negative, and at the same time also allows that service provider to follow workflow that is already programmed into the device that tells them in a positive case, was this severe malaria or not severe malaria? If it is severe malaria, gives the option of what drug to prescribe and an opportunity for referral and what else to be done as per the guidelines and protocols adopted by that country or by the international community. That will be done for malaria, it will be done for HIV, it will be done for IMCI, it will be done for ETAT, emergency triage assessment and treatment, or TB or any other condition. So this is transformative. Fio Corporation's clients in the field in the jungles of Colombia, in Tanzania, NIH centers, or collaborating centers of excellence and all that have validated these processes. They are now being actually utilized in a number of countries. What did I mention about guided digital diagnosis? As you might see here, the system, the DECI reader, this is called a DECI reader. It's very, oh my God, there's a wire over there. It's very light and it's handheld and it has got a space where you can put another DT. After you processed it and put it in there and incubate and hit a button, it starts timing it for you. You can do about 5 in a row and you will never make the error because it recognizes which RDT belongs to which patient at what time and lets you know. If you make a mistake and mix them up, it tells you no. If you do the wrong things, it corrects it. What have we done? We have suddenly transformed a system that is prone to errors and problems to an automated, accurate, not only accurate in terms of diagnosis, but accurate in terms of data capture. And the minute a patient, you finish with that patient, with no send button, uploads that through cellular networks that are available, and you know how much the penetration of cellular telephones are in the developing world. In Africa, it's got probably the biggest penetration. I think I sometimes get better network coverage in Meru in the eastern slopes of Mount Kenya, where I was born, than sometimes I get in my house in Rockville, Maryland. So this is transformative in my view. The second thing that is happening here is not only recognizing the RDT, but also the quality control that occurs in the processing of the RDT, so that errors are captured by the equipment and you do not require somebody to look at what is happening from wherever they are. But that can happen as well, as I'll tell you. The incubation period is correct and the interpretation is automated. So what happens at the end of all this? What happens is that you have accurate, complete, and timely data that is captured by a process that is embedded in regular care, regular routine care. You don't have to turn around and write on a piece of paper because every touch that you make on the equipment becomes a data capture opportunity. And that is all automated. So effectively, what you've done is created a system that not only helps the health worker do the job better, but at the same time helps that health worker have oversight by the equipment as well as managers who can view that data in real time and say, hey, Lillian, what did you just do? Lillian actually is a lab technologist in Meru Hospital in Kenya. But I'm able to do that just as much as the person in Nairobi is able to do, and so on and so forth. And that is because this device sends the information automatically into a cloud service which can be accessed using web browsers that are available to anybody. The other important thing is this, that this is GPS tagged, and a very important function of this device is that it uses high resolution imaging capability, so that for the first time you are able to take the image of the actual test. If they said it was negative, it will be picked up and it will it will be part of the permanent record for that particular patient. If it's negative, positive, or processed badly. So you are able to look back, and under normal circumstances, when you do a test, you prick, it's a biohazard, hazardous material, you throw it in the dustbin. Gone forever. You never know what it did. You can only rely on the report that they wrote that it was positive or negative. This time, you can't go around that. You have a permanent record of what was done at that point in time. So, then you can actually, that image, you can pull it out from wherever you are and be able to see what they did and be able to refer to them and say, you know what, this is too much blood, so the whole thing is muffled up. Or it was smeared and therefore it was invalid. Or blood was put in the wrong place in the buffer well. And believe you me, that occurs very, very frequently. And they still go ahead and make a diagnosis and prescribe treatment. So that's a major problem. Now, they can pinpoint inappropriate case management and intervene. The equipment itself does that, but also the service manager is able to do that. This is a Google map of Kisumu County. That's not me, I hope. Okay. All right. Okay. Where this, but some of the work that I would like to demonstrate happened. I will very quickly refer to a case study in Meru County. That happened to be the county I was born in, where, in fact, they were so impressed by work done by the Ministry of Health, by KEMRI and others, and decided to adopt the system, and now it's working. What drives the care, visits for care in this particular place? They thought actually they had an incidence of 33% of malaria, respiratory tract infection about 27%, as you can see the numbers there. But actually, they asked themselves the question, what drove revisits to these facilities? And they found, in fact, they hypothesized maybe they were not doing proper diagnosis, syndromic management, poor diagnosis skills, or poor efficacy of the drugs themselves. So they decided to deploy the system in the county. Within 5 weeks, you can see the dramatic decline in error rates and improved performance of RDTs for malaria. Effectively, they actually were within the same period of time to demonstrate that you didn't have an instance of 33%. And Professor Mugaya will agree with me, Meru is really not a malaria endemic area, and that's absolutely ridiculous. It is 0.6%. 0.6%. How much wastage is that in terms of resources? In the case of HIV cases, actually they demonstrated they had a reasonably close to the estimated rate of HIV infection using this system that I've just talked about. Similarly, in Kisumu, and a research that is funded by Gates and implemented by Kenya Medical Research Institute, that was to test for malaria with rapid diagnostic tests and collect information, demographic and otherwise, they were able to demonstrate that, in fact, what they hypothesized that the health work performance would be improved, that the accuracy of diagnosis would be improved, completeness of data would be improved, and timeliness. That was the reason. That's the only way they could be able to demonstrate whether the nets that were being used, LLINs, could reduce or prevent malaria infection. And there is a video that you'll be able to see at some point that showed that. A very important finding here, again, because this is a community health workers going from house to house. These are not even nurses or clinical officers. It's community health workers with minimal education. They were able to demonstrate high levels of usage of nets. But what else did they demonstrate? By capturing this information, using this, they showed that actually the nets were bad nets, poor nets. They could measure Does it allow a finger in, a fist in, or a head? The hole in the net. And they showed, in fact, that the government needed to do something drastic to ensure that the nets were good enough. The conclusion from these two case studies were that the cost per useful data set provided by Fionet was estimated to be about 25% less than the cost of using paper-based data management methods. And Fionet significantly improved the quality of data gathered, about 10 times greater rate of complete data, transparent, objective diagnostic data, as well as 87% of aggregated data available in less than 1 day. In fact, over 70% within 10 minutes, because it's being uploaded there and then, as opposed to waiting for months and months and months to get this information that would be inaccurate and problematic. Investigators concluded that Fionet significantly improved overall data quality and management of that program. We are working in busy clinics, busy facilities, and in remote communities. Private pharmacies in Ghana and in Nigeria and other places, all of them can be facilitated to improve diagnostics, care and treatment, data capture, and use of that data for decision making. Just to demonstrate, $7 billion was spent by Africans in cell phone fees in 2013. That is the measure of penetration in those countries. If you utilize that opportunity, that gives a tremendous opportunity to apply that technology for healthcare. Okay, thank you very much. I had since you're all here, I had a 4-minute video. 4 minutes. Can you allow that to show that? Because if you do, you can even have tea and coffee and dance a little bit as you watch this.